So the case scenario that you have got is a slightly different one, but this is the one I just prepared just for this thing. So challenges is mainly the anticipated difficult airway for conventional method of securing airway by IV induction, muscle paralysis, laryngoscopy, and intubation. Especially the case you have described where the mouth opening is really restricted, laryngoscopy will be totally impossible. And of course, with the fixed flexion deformity, if it is there, conventionally positioning the sniffing position or morning air position is also not possible. So that makes it an anticipated difficult airway. Then, if the patient has had extensive burns in the upper and lower limbs, IV access also may be challenging in these cases. Then, if it is an extensive resection of the scar has not become mature fully, then there is a possibility that blood loss will be quite severe. So, you have to anticipate that blood loss and reserve adequate blood. And there is a need for restriction of neck movement during post-op also to preserve the skin graft in position. So it will be kept fully extended and patient has to remain in that position. So adequate analgesia is required, otherwise patient will toss around the head and it will cause failure of the graft tape. And psychological problems in patients like depression or which cause post-traumatic and post-op restlessness or delirium. So the management problem will be airway, which can be managed by awake fiber optic intubation through the nasal route invariably under topical analgesia. The second thing is release of contracture for getting a neck extension under local or permission local anesthesia, followed by IV induction and paralysis and intubation. Or LMA also can be used once you achieve sufficient extension of the neck. The third can be small subanesthetic doses of IV ketamine, and if the patient is breathing spontaneously from inhalation agent, either by mask ventilation, if you can have a adequate mask fit. So that will be the plan C. And complete release under permission local anesthesia with IV sedation also is possible because this is only a very superficial procedure. So these are all the answers that are required for the short case that is commonly asked. As you said, sometimes they may switch over to the initial acute burns management, especially in the neck. If you have a contracture neck case, they may ask you all about inhalation injuries, like carbon monoxide poisoning, cyanide poisoning. If the patient has to sustain the burns in a closed room, then they might have inhaled all these noxious substances, and that may cause a problem during the acute phase. Or they can completely go to fluid management in acute burns, like Parkland formula, the Brooks formula, all those things, and the management of acute burns in intensive care unit. As an intensivist, how will you manage an acute burns in the ICU? So all the question can be asked, so you must be prepared to answer all those things.